Welcome to the 246th of the COVID calls. This is a daily discussion of the COVID-19 pandemic with a diverse collection of disaster experts. My name is Scott Gabriel Knowles. I'm a historian of disasters at the Korea Advanced Institute of Science and Technology. I'm coming to you live from Daejeon, South Korea. Today is a discussion of the COVID crisis in elder care with Lori Smitanka and Jasmine Travers. Just a reminder, you can catch COVID Calls live at its new time, weekdays at 5:30 p.m. Eastern Time on YouTube. Just go to the COVID Calls YouTube channel to watch. You can also hear COVID Calls anytime recorded as podcasts on Spotify, iTunes, Podbean, or anywhere you get podcasts. You can keep up with COVID Calls via Twitter using the handle @USOfDisaster or @COVID Calls. Please do help spread the word and send suggestions for future guests and future topics. And as always, please feel free to suggest yourself as a future guest. As of today, March 25th, 2021, there are 2,746,147 deaths from COVID-19 globally. That's according to the Johns Hopkins University Coronavirus Resource Center. The death toll in the United States from COVID-19 has climbed to 545,282. 16,540 people have died in Ecuador from COVID-19, and the death toll in the Philippines from COVID-19 has now reached 13,039. The way to bring some humanity to the numbers, I've been reading a life story or a story of advocacy for those impacted by the pandemic, and I'd like to continue that now. The headline is, "A generous and caring person, well-known nurse and nursing home aide Sarita Quinn dies of COVID-19." This was published in the Des Moines Register, March 25th, 2021 by Amber Momond. Sarita Quinn wore her personal mantra on her arm. Emblazoned in black ink and adorned with decorative flowers, she could always look down and see it right there on her forearm. Loyalty is everything. For her, the phrase was a reminder to stay true in life and work and to keep friends and family close, fight for them, and offer them support when they were in need, always. You don't have to call them 24/7, but you have to make sure you're there for that person, said Shamara Quinn, Sarita's daughter. Sarita repeated the beloved motto so much that her loved ones came to embrace its essence too. Loyalty is everything for all of us, Shamara said. Now facing a lifetime without their matriarch, the mantra lives on with Sarita's friends and family. After fighting COVID-19 for about a month, Sarita died on December 21st from complications of the disease at the University of Iowa Hospital in Iowa City. She celebrated her 45th birthday in the hospital just 10 days earlier. Quad Cities native, Sarita attended Davenport's Central High School and Hope Baptist Church in Bettendorf. She married Felix Quinn in 2009, and the new family settled in Eldridge. Sarita, a nurse, was a well-known caregiver at several area nursing homes. But in March, Sarita left her job at an assisted living facility. With severe asthma, she just couldn't take a chance on getting the virus, her daughter said, but it found her anyway. Sarita was very close to all four of her children, as well as her stepchildren, but Shamara and her mother shared a special bond. Shamara wasn't in her own room, she was in her mom's. They'd pass time swapping stories about their days and imagining their futures. When Shamara had trouble finding her path, she would always go to her mother for inspiration and advice. During her senior year of high school, Shamara struggled to find the motivation to graduate, but her mom pushed her forward. She would tell me, "I know you're capable of it, you're my daughter. I know you can do anything," Shamara said. "You hear it from your mom, you know that you've got to do it." And when Shamara walked across the stage and collected her diploma, Sarita cheered at the top of her lungs. "She was the first person I saw, and I just ran to her," Shamara said. She wasn't at work or at home. Sarita enjoyed fishing, taking walks, and wine with friends. Eternally happy and habitually helpful, Sarita had a smile that would light up the room, family said. She was strong and independent and just plain caring, her daughter added. Sarita will be remembered as very outgoing and generally loved and cared about everyone, her family wrote in her obituary. In the wake of her death, a local community group set up a GoFundMe account to help family with funeral expenses. The fund started with a goal of $5,000, but within a day, more than $19,000 had been raised, and since then, the funds have grown to more than $25,000. I think a lot of people knew my mom, Sarita's son, Marquand, told the Quad City Times. My friends knew her as a really funny, outgoing person who enjoyed having them in her home. My mom was a generous and caring person, he added. I just had no idea the community would show this kind of love and caring for her and my family. Sarita was diagnosed with COVID-19 the week of Thanksgiving, soon after she was sedated and put on a ventilator. Just a few days before Christmas, her family gathered at her bedside to say goodbye. I held her hand and I just told her that she did everything right as a mom and she never failed us, Shamara said. We were going to be okay. Sarita couldn't speak, but the gathered knew at least one of the pieces of advice she'd want to leave. It was written right there on her arm. Loyalty is everything. Okay, I'd like to turn to the conversation for today, and let me introduce my guest today to you. Lori Smetanka is the Executive Director of the National Consumer Voice for Quality Long-Term Care, the leading national nonprofit advocacy organization representing consumers receiving long-term care and services in nursing homes, assisted living facilities, and home and community-based settings. Lori has testified before Congress and served on federal task forces, technical expert panels, and working groups on long-term care issues. From 2004 to 2016, she served as the director of the National Long-Term Care Ombudsman Resource Center, providing technical assistance, training, and support to the 53 state and more than 570 local long-term care ombudsman programs across the country. She received a BA from Indiana University of Pennsylvania and a JD from the University of Dayton School of Law. My second guest is Jasmine Travers. Dr. Jasmine Travers is an assistant professor at New York University Rory Myers College of Nursing. Her career is dedicated to designing and conducting research to improve health outcomes and reduce health disparities in vulnerable older adult groups, using both quantitative and qualitative approaches. As a health services researcher, she has leveraged many data sets to investigate these issues and has published widely on the topics of aging, long-term care, health disparities, workforce issues, and infections. Prior to joining the faculty at NYU, Dr. Travers completed a postdoctoral fellowship with the National Clinical Scholars Program at Yale University and a T32-funded postdoctoral fellowship at the new Cortland Center for Transitions in Health at the University of Pennsylvania School of Nursing. She completed her doctoral training in health services research with a specialization in gerontology at Columbia University School of Nursing. Lori Smetanka and Jasmine Travers, thank you so much for joining me today on COVID Calls.
Thank you. Thanks. Nice to be here.
Yes, thank you, Scott, for having me. I'm glad to be here with Lori.
So I'd like to start the way I usually do, just find out where you're calling in from, what the pandemic is looking like there today, and perhaps what the vaccination situation is looking like there today. And Jasmine, can I start with you on that, please?
Sure. So I am calling from New York City, New York. The pandemic situation over here, I would say, at the beginning of the pandemic, we were like known as the epicenter, right? And then we started doing better than the rest of the country. And then now we're starting to do, we're starting to go downhill a little bit. Manhattan, where I am, we're doing a little bit better. So in total, New York has 1.8 million cases and 49,231 deaths from the coronavirus. New York City particularly has 817,000 of those cases and 30,793 of those deaths. And just kind of thinking about the 2-week average, we've had an increase of 37% of coronavirus cases and then 29% increase of deaths. So when thinking about that and why this is going on, for one thing, we haven't opened up vaccine eligibility to the entire group of adults like other states have done. In regards to where we stand, though, with the vaccination rate, New York has had 27% of our individuals given one dose of the COVID vaccine, and 13% have been given both doses. And that's in comparison to 26% of the US that has been given one dose and 14% has been fully vaccinated. So we're doing a little bit better with vaccinations for one dose when compared to the United States. Just recently this week, though, we have lowered our vaccine eligibility to the age of 50. So again, we haven't opened it to all adults, but we're making our way.
That question of when it will be made available to all adults in the state of New York is such a difficult one, because it's also wrapped up, as usual with New York, with the sort of political controversy around the governor. It doesn't seem to matter who the governor is. That's kind of the way things work in New York. I don't know how much have those issues been vexing to people there in New York, and particularly people on the front lines, Jasmine, or they're just doing the job and the politics will take care of itself?
When you say vexing, what do you mean, Scott?
So troubling to them that, the vaccine isn't fully available as it might be in some other states, and sort of questions around, that are being brought around the governor's office as well.
Of course, people want to be able to get the vaccine. We have people coming in. I also work on the front lines administering the vaccine. And what you've been hearing on the street is that there's extra doses in the evenings, right? So there are long lines of people just trying to get these extra doses. And these extra doses aren't like hundreds of doses, aren't even in the tens. They're probably like 3 doses or 4 doses.
Really?
We'll have lines going out the door just for those 3 doses. It's incredible. Where it ends up being prioritized by age, right? But we'll still have people who are in their 20s, in their 30s lined up for the doses. But if there's someone in their 50s and then lined up for the doses, they're going to get it. So that's just a little example of people who want the vaccine. There's people who are having various events, over the next couple of months. I also was working with a woman who's getting married next month, and she was like, oh my goodness, like, I just really want to get the vaccine. I have 40 people coming. A lot of them are vaccinated, but I want to be safe as well. And the thought that you can't even provide the vaccine to this person who is in her late 20s is just, it's disheartening. But at the same time, recognizing the need to adhere to policies currently and really prioritize those groups that we said are in specific phases. So it's a lot of tension, I would say. And people, of course, they want the vaccine. And when you see other states doing things, it's like, why can't we do that? Why can't we open it up to everyone, especially given that the Johnson & Johnson is on the market now as well?
Right. Well, thank you for that. Let me bring Lori in. Lori, same question. Where are you calling from, and how is it looking there?
Sure. I'm calling from Rockville, Maryland, and I'm just north of DC. And here in Maryland, we've had about 400,000 cases and a little over 8,000 deaths in the state. And the county that I'm in, Montgomery County, has had a little bit higher numbers than some other areas around the state because we are so close to DC and main thoroughfares going through. So some of our counties are a little bit higher, as ours has. So we also haven't opened up as much as even other parts of the state have. There's still some pretty significant restrictions that have been put into place, although just recently, the governor and the county executive have opened up for limited indoor dining again in some areas in the state. But our county is a little bit behind where the state is. Usually we're about a week behind where the state is in terms of how things have opened up. Vaccination rates here, we, similarly to what Jasmine said in her area, we've got about 28% that have had the first dose and about 14% that are fully vaccinated in our state. But again, in Montgomery County, we've seen a demand for the vaccine is higher than supply, and people have been really frantically looking for how to get it because we're one of the bigger counties too in the state, and the doses have been distributed more evenly in terms of numbers instead of by population. So that was a challenge for a while, but the governor has assured us that additional doses are coming. They've opened up some mass vaccination sites in the state, and they've said that pretty much any adult who wants a vaccine will be able to at least get an appointment for one by April 27th. We'll all be eligible by April 27th. So it's coming.
That anticipation is excruciating, and it's so interesting. I'm in South Korea, where the discourse around getting the vaccine is very different because the infection control has worked here. So it's not that people aren't anxious to have it, but the way that you're relating the story there is it's really moving, because you can imagine people literally calling around and trying minute by minute almost to find out what's happening. Lori, just to follow up quickly, I've also been fascinated to follow this pandemic story in a place like where you are, where you have Virginia and Maryland and then the District of Columbia all coming together. And as it was earlier in the pandemic, those rules can be quite different at different times around lockdown, what's open, what's not open. It sounds like a similar kind of thing is playing out with vaccination. It's a region that's integrated, but then at this time you find out there are important, quite local differences.
There absolutely are, and because of the particular area that I live in, the DMV, we call it the DMV area, whilst there have been limitations on movement between the states and where people have been asked to quarantine or isolate themselves if you're moving across borders, that doesn't really work here because, so many people from Maryland and Virginia work in the district and vice versa, that there's a lot of coming and going and back and forth. So it's been a real challenge.
Well, thank you for that. And let's turn to the conversation. So many aspects of this I want to ask you both about. And Jasmine, I'm going to start with you. And it's a really basic question, basically for myself, although other listeners may benefit by this, just to kind of get a general sense about the different types of facilities that both of you, I think, study on. Jasmine, and I'll ask you about this first. What are the different options out there in the United States for older people who need care? What, sort of break it down for us a little bit, if you would.
Sure. And I just wanted to add real quick, Lori, I'm very familiar with the DMV. I'm actually from Gaithersburg, Maryland. So Montgomery.
Oh, we're neighbors then.
Yeah. We are neighbors. So yeah, my passion is long-term care across settings. So when we think about the settings of long-term care, there's home and community-based care, there's nursing homes, and there's assisted living. I've been spending a lot of my time within nursing homes the past year because of, the pandemic. And that's actually where I started my focus when I began my research about 8 years ago. But when thinking about these different settings, so nursing homes, that's probably going to be the most highest care need, right? So these are older adults who may need multiple assistance with activities of daily living. So that is feeding, toileting, dressing, mobility, those types of activities that they're going to need support for, or they could have cognitive needs, social support needs that they're not able to get in the community. Within nursing homes, they're going to have two different layers. They're going to have your skilled nursing facilities and then your nursing homes. So the skilled nursing facilities are for people who need short-term care. That's what we call it. That's less than 100 days of care. And those are for people who need more of the rehabilitation. So they might have gone into the hospital, broke their hip, got a hip replacement, and then now go into the nursing facility for some physical therapy so that now in a couple of days, they'll be able to return in the community. The nursing homes are those who are going to be staying there for more long-term. So they need more of the custodial care as opposed to this skilled level care, just more long-term support with those activities of daily living that I spoke about before. And then home and community-based care can range. So you can receive care in your home setting where an aide, nurse, physician, nurse practitioner comes in your home, provides care, assistance, medical needs, or also activities of daily living support. Or you might go, in addition to that, go to a setting like an adult day care setting, or programs of all-inclusive care for the elderly. You could go to where you receive comprehensive care over a couple of days, and just not even over those couple of days. In general, they're responsible for all of your care needs. So these are to keep people out of nursing homes who would probably be who are definitely eligible for nursing home stays. So those are some of the settings. And then there's the assisted living. So assisted living is in between the home and community-based care and nursing home. So these are people who need some type of support, so not able to remain in their homes independently typically, but they want to maintain a social, active lifestyle. It may require some assistance, but they are mostly independent. So they don't need access necessarily to 24-hour nursing care, or nursing home stays are going to need access to 24-hour nursing care.
Just to follow up, Jasmine, in recent years, what kinds of trends have you seen in terms of people availing themselves of those different kinds of options?
Yeah, no, great question, Scott. An area where I'm very much interested in, you introduced it in my bio, was kind of these like vulnerable populations. And I've been looking at these trends in nursing home use and nursing home access. So specifically when thinking about populations, when we look at our racial ethnic minority populations, such as the Black and Latinx community, traditionally, historically, they've used informal care services. So care services in the home provided by family members, for example, or friends, right? Where we would see more of the nursing home stays being used by those from white races, where now over the years, we're actually seeing an increase in nursing home use among Black and Latinx populations, and a decrease in nursing home use among the white population. And what we're seeing specifically is that it's not even just like this increase and decrease, it's more of a disparities in access to preferred options also. So we're seeing that white older adults are moving into preferred settings such as assisted living, where Black older adults and Latinx older adults are moving into these nursing home settings and are experiencing disparities in care, disproportionate care, pressure ulcers, increases in pressure ulcers, restraint use, antipsychotic medications, not receiving vaccinations. So those types of things that they're experiencing. And then on top of that, the actual access to nursing homes in their communities are closing because they're more likely to be in nursing homes of poor care that are for-profit or have an increased proportion of Medicaid residents, where we'll talk about, I'm sure, about Medicaid and, funding and all of those types of issues. But that's kind of the whole, or some of the trends that we've been seeing in regards to use and access, where on top of certain communities needing more access to care because they don't have that same type of care that they once had in the homes because of, family members needing to work outside of the homes and having multiple, responsibilities. We're seeing an increased access and increased use in nursing homes and decrease in preferred options.
Lori, just to bring you in and build on what Jasmine's been talking about here, maybe you can tell us a little bit about how regulation works, who has oversight of these different kinds of sites and facilities. And I guess we'd also need to get a general sense of what they cost, although I'm sure that's highly variable across the United States and around the world, but maybe there's some general sense of how they're regulated and what it takes to keep people in these kind of facilities.
Sure. So, so much of our system is driven by the way it's financed and structured that way. We have Medicare and Medicaid that is available to people who, the Medicare is generally for people who need skilled care, as Jasmine said, going in for short term into a nursing home. And then we have Medicaid, which is often available for people who might need longer term supports, but it's really very focused on the institutional based model right now, where nursing homes are certified for Medicare and or Medicaid. The majority of them are, and that's really the preferred system according to our financing model at this point. So most people find themselves ending up in those settings, even though they may not want to be there. Where we've seen that there's more people wanting to stay at home or be in community-based settings, but they're so expensive that, and the financing models haven't kept up with that. We're seeing trends move in that direction, where we're seeing greater accessibility for Medicaid in community-based settings or in assisted living right now, but it doesn't meet up with demand, and it doesn't often generally cover the full range of services that people need, or even the housing that people need. So we're still really imbalanced in that respect. In terms of how people access the services. Nursing homes are regulated at the federal level. Medicare and Medicaid are federal programs, and so they're certified at that level. And right now, nursing home care is generally about $85,000 a year to $100,000 a year for care. For a semi-private room, it's about $85,000 and up to $100,000 for a private room. And most people rely on Medicare or Medicaid in order to live in those settings. Assisted living, other types of congregate care like personal care homes or even home care are more licensed or focused at the state level, where each state sets its own policies, its own rules for licensure, for regulation. So as you can imagine, the requirements vary widely across states in terms of what's available, what's allowed, and then the costs with the congregate care or the home care settings vary significantly based on where you are and what services you need.
So just to follow up and make sure I understand, and thank you for that. So nursing homes are regulated at the federal level, and that regulation is driven because of the funding model, Medicare or Medicaid for long-term care. So then just to go a little further with this, where does the state and federal regulation overlap, or where does one leave off and the other picks up?
Well, so the oversight of nursing homes is a state-federal partnership, and it's generally through the Medicaid system. So despite the fact that when nursing homes get certified for Medicare or Medicaid, they agree to meet certain federal requirements, but there are partnerships with the states in order to oversee and monitor that. So there's agreements with each state where they have state surveyors who will go in and assess to ensure, excuse me, that nursing homes are meeting quality standards, for example.
So just to follow up on this, because I think it's been, and I'd like to hear from both of you on this. And Jasmine, let me ask you first. I mean, there've been so many reports, and the statistics, the aggregate statistics around COVID-19 infection rates in nursing homes are staggering. But I sometimes get a little lost in the coverage because there seems to be, it's been rough in all of these different kinds of settings that you were talking about, Jasmine. I mean, I think the worst has been in nursing homes, but older Americans across the board have suffered terribly in COVID. So I guess I'd like to engage a discussion with both of you about these different kinds of settings and why has it been so bad in these places, Jasmine?
So just to give you some numbers really quickly, and I know we've heard, some of these numbers very often, but as of March 4th, there were 174,000 residents from long-term care facilities that have died from COVID, which makes up a little bit more than a third of all of the COVID deaths, although they make up less than 1% of the population. And when thinking about the cases, they've only made up, this group in nursing homes only made up 5% of the cases. And Scott, you talked about, older adults in general, right? So we see an issue within nursing homes, and then we see an issue within the older adult population across the board. So in all settings, older adults have accounted for 80% of our country's COVID-19 related deaths, which make up only about 14% of the COVID cases. So why is this the case, right? What went wrong? There's a number of things, and I mean, I could list so many things. One of the main things that I'm going to start off with, though, is ageism and the devaluation of our older adults, which is going to capture the whole gamut, right? It's going to capture nursing homes and out in the community as well. We don't care for our older adults and those who care for our older adults. If the same crisis was happening in our child care facilities, I'm quite sure that efforts to guarantee safety to this population would have been prioritized and accelerated. It wouldn't have gone this long or to this extent, right? And then we think about, if we go just in more of a granular, if we look at nursing homes, right? Nursing home residents, they're going to be typically older adults with high levels of chronic illness and impairment. So they're going to be susceptible to severe complications and mortality from COVID-19. Yes, that is the case, right? But when thinking about nursing homes, unlike the hospital, that's someone's home. These residents live in close quarters with one another. So it's going to be quite challenging to quarantine residents once they are sick. And then you have caregivers, the nursing home workers, aides, who they move from one room to another to assist the residents, which increases the spread or the chance to spread infections. Then we had issues when it came to, additionally, with the workforce, right? And the biggest problem was when we looked at the community spread. So the community spread and the size of the facilities. So depending on what was going on in the community, that's what we saw was going on within the nursing homes. Mm-hmm. When we look at the specific composition and the racial ethnic composition of various communities, for example, if essential workers, were living in communities that were increased racial ethnic minorities, we would see higher COVID cases and then higher likelihood of people working in essential positions. So this also increased and exposed them to infection, and also these workers lived in crowded conditions where any virus brought home would be easily passed through extended families and then, therefore going back into these settings. So it's primarily what was going on in the community and then now bringing it back into the nursing home settings and then not having the resources and the supports within nursing homes that, for example, hospitals had. And I know we were all stretched, right? When thinking about hospitals were stretched as well. But nursing homes were stretched by far, multiple times when compared to the hospital setting. And then thinking about the infrastructure within nursing homes and the need for nursing home workers to work multiple jobs because of the low pay. So these structural inequities that we're seeing in nursing homes. So if you need to work multiple jobs, and that increases one's risk by being at, for example, another nursing home institution and being asymptomatic on top of that. So spreading the virus from one place to another also increase the risk.
I would add to that, though, too, that in addition to everything Jasmine said, which I agree with, the nursing homes also were very ill prepared to handle any sort of crisis like this. What we've seen is that nursing homes generally don't have enough staff available to provide adequate care for the residents, and that became even more of a crisis during the pandemic. And there's been a history of problems and concerns with infection prevention and control protocols in nursing homes, where significant percentages of nursing homes had year after year deficiencies cited against them for not following proper infection control protocols. So that was another factor, I think, as to why we saw such problems in these facilities, because while certainly the community spread did play a part in the likelihood and incidence of COVID getting into a facility, it was a factor in the spread in the facility. We also saw that nursing homes that had done better jobs with staffing, for example, with staff ratios in terms of the makeup of staff that were available, as well as those that prioritized infection control protocols, did better in the long run than other nursing homes did.
Lori, can I just stay with this for a second? Because this idea that nursing homes were ill prepared to handle a crisis, that makes sense to me, but at the same time, it doesn't, because I don't know, with an easily predictable public health emergency of this type, why not? And particularly maybe on that regulatory side, why had regulators not been making higher demands of nursing homes to demonstrate that they could meet, as you just said, the sort of staffing capacity needs in this kind of a case?
That's been a long-standing issue, and that's actually one of the things that we've seen throughout the pandemic, are some of the long-term systemic problems we've seen in long-term care facilities really had the spotlight shown on them during this pandemic. And so the lack of preparedness has been an issue that I think we've been dealing with for a number of years. It really started back around Hurricane Katrina, when we saw so many nursing homes were ill-equipped to handle that type of emergency. And there's been a lot of emphasis and focus on emergency preparedness in nursing homes through the years, but we haven't quite had the enforcement of standards, I think, that we needed in order to ensure that the nursing homes actually were prepared. And ironically, there were new regulations that were issued for nursing homes around emergency preparedness in 2016. And one of the new provisions in there was for nursing homes to have a plan in the event of a pandemic, such as this one that had occurred. And unfortunately, I think too many may not have had an adequate plan put into place. That doesn't excuse the failures of the systems outside of the nursing homes to play a part too, in terms of lack of support that they were getting during the pandemic. But the nursing homes do have some level of responsibility here also.
Just so, I mean, this is again kind of a naive question, but and Lori, I'll put it to you first, and then Jasmine to you. Do I need to understand that as an issue that these nursing homes are running budgets very close to the bone, and so when you ask them to do additional things like be prepared for emergency staffing or to make an emergency management plan, that they literally don't have the resources to do it? Or do I need to understand this as this is a profit-centered sort of model, and they've been keeping their profits where they wanted them to be, and so they chose between profit and care? And I put that in a binary, so maybe that's not the right way to think about it. But I guess I feel like in some sense it's inexcusable if we could put a dollar figure of profit on this and say this has just been a profit calculation and they could have been prepared.
Well, I think there are multiple factors. I think in terms of the accountability of standards, that has not been sufficient. We need better accountability, holding the nursing homes accountable for meeting standards. That absolutely is something that we need to focus on. But in terms of how they spend their money, that needs much more transparency and accountability as well. That's actually was the topic of a hearing just today in the House of Representatives, where they looked at the money that nursing homes receive. And, what we see from this industry is they often ask for more money, but we need a better sense of, are they using it properly for care, and ensuring that money that they do receive is directed towards care. We don't have really those answers right now. So what we have been asking for is much greater transparency and accountability for how they're spending the dollars that they get. For some, we are concerned that there is use of the money for profit centers, particularly when we're looking at private equity firms that are increasingly buying up nursing homes. When they go in, we see that they're cutting staff, they're cutting costs, they're cutting supplies, which leave nursing homes even less prepared. But just across the board, we need much greater transparency and accountability for how the money is used.
Jasmine, just giving you opportunity if you want to comment on any part of that. And then I also sort of want to bring the essential workers into this discussion as well, talking about nursing staff and physicians and maintenance staff in these kind of facilities and the stresses they've been under.
Yeah, no, I think Lori really hit the needle. When thinking about this regulation, right, and then this need to have emergency planning, and this need to have, certain amount of staff and all of these other regulations that are in place, and then you say, well, what happened here, right? And thinking about the historical traditions that we've seen with infection control and how nursing homes have done poorly, right? They're constantly cited for infection deficiencies. So what is going on here, right? Where it's the accountability piece that Lori talked about, and this understanding or this idea that, like, what are the regulations even doing to begin with? It's something that nursing homes are just looking at it as something to gain, right? That they just like figure out how can we, meet what will give us the check off and say that we're good to go, but it's nothing meaningfully being changed and being addressed, right? And these are why we see these issues in, Lori talked about Hurricane Katrina and this Hurricane Irma in Florida, where in the nursing homes, a number of people died because, there weren't generators, there weren't different things in place. And when you go back and you look and you say, oh, well, they were cited for this back then. And okay, well, then whatever happened? Why wasn't the, necessary things put in place to fix what was supposed to be fixed? And this is continuously going on, right? And then we get all flabbergasted, right? And Scott, you're like, oh, why does this happen? What's going on here? And it's these things that we're just not intentionally following up on when thinking about these regulations. Are the regulations doing what they're supposed to be doing, or are they perpetuating, just continuous bad care? And then just another thing, it's like the consistency between these inspections across states, right? Where it differs, or you go in and you're like, oh, this is already a good actor. We already know they do well. So you don't look into these issues as intensely as you would another nursing home, but the same things are going by. And then the last thing that I'll say real quick is a report came out, I think it was from the New York Times a couple of weeks ago, right? Where, and this was just, it was so sad just for me to read. I was almost in tears when reading about a nursing home and a resident who was raped by a healthcare worker, unfortunately. And this was reported, and in the report, it was cited as like a low harm, and you think, like, how could something like that be cited as a low harm? And in this whole in the New York Times, they're saying how this often happens. Things that are detrimental are just cited as just low. So these are the issues that we need to really address when thinking about this accountability that Lori discussed, and this transparency and the need for consistency, and really, meaningfully thinking about what needs to be changed and what does that look like.
It's a terrible story that Jasmine just related. And Lori, I mean, it also brings me back to something Jasmine said earlier, which is that she puts a lot of this at a sort of broader societal level on ageism. And I can't help but wonder, I'd like to sort of get your thoughts on this, that why aren't these things traditionally at the top of policymakers' concerns? I mean, the AARP is one of the most powerful, well, I'm going to say this, but maybe you correct me and tell me I'm wrong. I thought the AARP was one of the most powerful lobbies in the United States. Look at voting rates. Older Americans vote at much higher rates than younger Americans do. Among middle class white Americans, wealth accumulation, it really picks up as people move towards retirement age and just beyond. So just looking at that, one would think there'd be commission after commission after commission looking at these problems, but that's not what I'm hearing from you.
No, that's not what happens. And, I think ageism really is a factor here, as Jasmine had said. and the other piece of it is that the nursing home lobby is also extremely powerful across the country, both at the state level and at the federal level. And they have a lot of high-paid lobbyists that are constantly interacting with policymakers and pushing their own agendas. And so we don't see the attention and the accountability that we absolutely need to see being put into place. We do need to see that. Most of the focus has been on in long-term care, in healthy aging, or also in keeping people at home. That's where the attention has been spent probably over the last 20 years, where there's not been that attention paid to real quality in nursing homes in that setting. And people have suffered as a result of it. We have high turnover. Recent reports coming out show that the average turnover rate in nursing homes is 100%. The turnover rate of staff in nursing homes is 100%. You can't effectively run an institution with 100% turnover in a year. And that's not only at the direct care level, but it's also high turnover in the administrative staff, in the licensed staff. So it really affects the quality of care that's being provided in those settings.
That turnover rate is astounding. So on
Astounding.
average, so that means in some places people are staying a little longer, but in other places it's within a year you're having multiple.
That's right. Which makes
turnover.
it difficult to attract staff. I mean, there's there is a lack of people that have been willing to work in the system. It's a difficult job to go in and work in a nursing home. You're paid low. You don't get benefits often. It's a very difficult job. There's often not a career ladder that's put into place. So attracting people to the profession is something that we really have to be focused on, and that is one of our priorities. Staffing has been our top priority since the inception of our organization 45 years ago, but we are putting additional emphasis on the need to pay a living wage to people that are working in long-term care, to ensure that there are adequate staff on hand, because that is what's going to make the biggest difference, and not just direct care staff, but also licensed staff.
Jasmine, I'd like to hear from you on that, particularly about staff. And, there are chronic issues here, obviously. Even like the obituary I read, people who are having to maybe work in multiple different elder care facilities because they can't get full-time work in one of them, or maybe they're working full-time in one of them and additional hours, probably more likely, in others of them. How well are we tracking stress and strain on those staffs, burnout? The COVID rates, have been so many caregivers who have been sick and who've died. Probably, I imagine financially, there's enormous pressure on some of them, even if they were sick or maybe thought they were sick, to go ahead and go to work, because it was a choice between, putting food on the table or, possibly making others ill. I mean, it just seems like a sort of impossible set of trade-offs here to put in front of these caregivers.
Right. So in general, we don't spend enough time looking at burnout and pay enough attention to it. And when thinking about the long-term care setting, nursing home setting, forget about it. How much have we really brought up, the burnout that these nursing home workers have been experiencing when it comes to low staffing, chronic low staffing prior to the pandemic. And then, thinking about what it looked like during the pandemic, the lack of resources. And then on top of it, it's like the lack of just attention to what they were experiencing, right? When we were celebrating, this was in New York and across some of the other states, but who was being celebrated? It was the hospital workers, as they left, 7 p.m., they were the ones who were being celebrated. But what was going on in the nursing homes? And specifically, I'll tell you, a quick story about my uncle. He's a nursing assistant, was working in the nursing home, ended up contracting COVID. And on one aspect of it, he was told to come back in the next day. He's over there, in the midst of just fear. This was early on in the pandemic in April, and that was the biggest things. He lives with my mom, who's his sister, and then my mom takes care of a number of older adults because she does adult foster care. And that was the biggest fears within the house, was to experience COVID in the home, and everyone's high risk. And he gets COVID, and it's almost like, what do we do? And the nursing home calls him and says, come back in the next day and we'll put you on a COVID unit. What is that? And then on top of that, he had to try to navigate. My mom was calling me for support to quarantine outside of the home. And hotels who were providing any type of assistance to nursing home workers said that an aide was going to receive a modified rate for a hotel stay, which the modified rate was $100 a night. We're thinking about 14 nights to quarantine. That's $1,400 for the 2-week stay without fees. How much do nursing assistants make? On average, about $12, $13 an hour. That's about $20-something thousand a year. That doesn't even make sense. But instead, we were giving physicians and registered nurses full hotel stays. What are we thinking, right? Yes, I am a registered nurse. I live in New York City. They were giving free hotels. They were giving City Bike memberships, Revel memberships. And I was elated, but then I had to really humble myself and recognize the privilege that I had when compared to these essential workers as well, who don't make, what I make necessarily, and cannot afford these things, and they didn't get the same types of resources. So that's how our system is set up, and how it creates this this disproportionate access to resources and supports, where we see the need for workers to work multiple jobs and not trust, the people that they work with, their supervisors or the system, because they don't feel like they're being cared for or they're being seen.
What a powerful illustration there, and what Jasmine was just talking about. Thank you for sharing that, because I think it shows sort of the failures in the thinking here, that you want to take care of essential workers, so we take care of some subset of them, but it's the same facility in which others who have been deemed sort of quasi-essential or unessential, they haven't been taken care of, and so they're coming to work, and that's one of the modes that infection spreads. So if infection control is what you really are after, you have to sort of imagine this as a full community or full ecosystem of a workplace. I think that just wanted to underline that, Jasmine, because I think that's a really important point to make here. And Lori, I guess I want to sort of bring you back in on this and see, thinking a bit about what can be learned from this. That's one thing that Jasmine was just talking about. I mean, what states have done this well? I mean, can we shine a light anywhere to say, okay, there were some cases where people were prepared, and we should point to that as a best practice in this moment? You don't have to be optimistic if you don't want to be. I'm not trying to force you to be, but I am trying to look for something to build on here.
Yeah, I'm and maybe Jasmine would think differently, but I'm not sure we could point to states that have really done a great job on this. I think everyone struggled with it across the board, and it was an issue of the spread of COVID, but not only was COVID so deadly for the residents who lived in these facilities, the 170 plus thousand that was mentioned earlier, frankly, that's an understatement, because so many, particularly early on, residents weren't even tested for COVID. So that's really an undercount. But the number of people also that died of isolation as a result of the lockdowns that happened in the separation from their families and from their essential caregivers was critical. One additional report that had come out in November estimated an additional 40,000 deaths in 2020 that had not occurred in 2019. Like, they were able to estimate, based on looking at numbers, you can estimate about how many people will die per year on average as just a normal course of life. And there were an additional 40,000 deaths that were indicated in nursing homes as of November. And we really believe that that was due to the effects of the isolation and the results of that, because so many residents suffered severe anxiety, lost the will to live, suffered from neglect, from not being properly cared for, from the separation from their families. So residents really suffered in two ways, not just from COVID, but from the isolation and the lockdown, being kept in their room for months and months at a time. One resident that we talked to regularly had not been out of her room in almost 6 months. She had not been taken for a shower down the hall for that amount of time, was maybe given a bed bath a couple times a week. They wouldn't even let her open the window in her room. And all she had was just her little half of a room that was not even able to go outside from there. I mean, that was a normal course for so many residents, and so many of them died as a result of it or suffered significantly.
Just a reminder that you're listening to COVID Calls, and we're talking about COVID-19 in long-term care facilities today with Lori Smetanka and Jasmine Travers, and we have a few minutes left. I want to come to the vaccination issue. We started with this discussion, and everyone's on the edge of their seat in the United States, waiting to see as the vaccine becomes more and more available. I know that, Jasmine, you study vaccine hesitancy, and I think that term itself, I did a whole week on vaccination and vaccine hesitancy in January on COVID Calls, and I learned a lot about the history of that and the difficult issues that it raises. You were quoted in a New York Times piece very recently talking about vaccine hesitation among staff working in care facilities and among older residents. I just want to read one thing you told the Times. You said we should not just chalk up a refusal, here in this case to get a vaccine, to that person's own wishes. We also need to look into ourselves and understand how we are approaching it. We can't tiptoe around the subject. It's one thing to want to be respectful, but we have to interrogate people around how we can better support them. I thought that was a really great quote and opened up for me a lot of sort of questions that I think you probably spend all day wrestling with yourself. Can you tell us a little bit about this issue and how we're coping with it?
Yeah, no, thanks, Scott. So just kind of this whole idea of vaccine hesitancy, and it definitely has been this buzzword, right, for a number of months, and kind of thinking about who's hesitant and who's accepting and all of those kinds of things. And the basis for that quote was, going beyond hesitancy, right? And we're saying, okay, why are these groups hesitant? What's going on? Okay, I feel like we've gone into that, right? We dug deep into that. But where is the actual work? Where are we saying, let's go ahead and put in work. Let's not just say, okay, these groups are hesitant. Oh my goodness, what are we going to do now? Or let them be hesitant. They've always been hesitant for these reasons. But let's try to reclaim, trust. Let's actually invest in these communities. Let's show that we care, and we need to actually care, right? We need to rebuild trust. And these are the things we have to address, the concerns that are in these communities, and we have to connect with community partners that will help, when it comes to building this trust. So we just can't leave it at, these groups are hesitant. Mm-hmm. Specifically, though, within the nursing homes, and you kind of alluded to this a little bit earlier, Scott, when I was talking about, this lack of attention to specific essential workers, for example, nursing assistants, right? Nursing assistants make up the largest proportion of nursing home workers, and they spend the majority of time with the residents within nursing homes, right? But we saw that they were neglected when it came to resources and supports early on. And then now, even when thinking about the vaccination, in long-term care, vaccination has always been lower in regard to influenza when compared to hospital settings. And then it's been lower among certified nursing assistants. Even now with COVID, we've seen vaccination lower among certified nursing assistants. And we've seen it lower among those who are Black and Latinx. So the thing is, are we going to sit there and say, okay, continuously seeing that they're more likely to say that they're not going to get the vaccine, where some say that they're going to get it later on, they just don't want to get it now? Or we're really going to actually include these groups into the conversations and into the decision-making? Because this is something that we neglected to do from, many years back. We should have already been including nursing assistants and other workers in conversations, in decision making, in resident care, hearing, what they're seeing, what's going on, how can we better support you, instead of talking at them and not talking with them. That's it. That's an issue that I've been advocating for that in regards to including nursing assistants and meaningfully, thoughtfully including them as part of the interdisciplinary team, which the Centers for Medicare and Medicaid Services has required that to happen, but they've allowed flexibility in what that looks like. But then now within the vaccinations, bring them into these vaccine campaigns, have them be ambassadors, right? It's going to support the efforts when you include them as part of the rollout, as opposed to this is what is happening and you need to either comply or you don't. That's the biggest thing that I would say. And then there's just a number of issues or a number of strategies, and Lori talks about there's not really any like best practices across the board. But one thing that has been helping is some nursing home facilities have been bringing nursing assistants in and other workers in to just really understand, why have you refused the vaccine, and how can I just really support you, and being empathetic in regards to what that looks like. And I'll say one more thing. So, for example, I was giving, and this wasn't specific to nursing assistants, but I was giving a presentation on just on COVID vaccinations. And someone in the audience, these were teachers and family members and parents of students, like high school students, and someone in the audience chatted and said that I must be working for the pharmaceutical companies based on the ways that I was advocating for the vaccine, right? And what I take from that is that I wasn't I wasn't showing empathy. I wasn't sharing, or coming down and recognizing the concerns that people have, right? I'm here saying the vaccines are effective, they're safe, right? And that's like the headline. But instead, you know what? Myself, I was hesitant to begin with. I wasn't sure. It was too fast, right? And I understand what you're feeling and where you're coming from. So if I changed my approach, it wouldn't look like as me supporting, this pharmaceutical company, but instead it's this person who gets my fears and gets my concerns. And now I'm going to really listen and open up to hear what they have to say.
But Jasmine, that's so hard because this pandemic has, like it or not, kind of pitted those who would be with science and those who would not. And it's forced people into these two corners. And it's not just the presidency of Donald Trump, although that played a role, but just the political polarization of the country, where somehow, denying the vaccine or denying the virus became a kind of a rallying cry for one political party or a subset of that party. So then when you go into those conversations and you try to have a nuanced conversation, and you start with empathy and you start with listening, it feels like the room's already sort of loaded up for conflict. And I don't think it's always been that way, or maybe it has, and I don't know. But I mean, Jasmine, just to give you a chance to respond, because it sounds like what you're describing is not just a need to approach this with a tone of empathy, but also you have to kind of address the whole last year of political strife in America. How can you possibly take that on all in one meeting with nursing home care staff?
Scott, that is tough, right? And I'm not saying that it's going to happen overnight. It's not going to happen overnight, right? And it's those continued touches. And that's why I say you can't just say, what do they say, throw out the baby water? What's the term? You can't just say, be done with it, right? Like it's too much. It's too hard, right? It's going to be every little touch, where people will come around. And you have to also think about when we first heard that a vaccine was being developed, right? And where you were and what you were thinking. Were you on the side of, I'm most definitely going to get it? Or were you on the side of, I don't know, I'm a little, squeamish about it, right? And what got you to turn around? For me, I am a scientist. when thinking about my networks and what I'm privy to based on social media, the different webinars that are always coming to my emails, all of the different information that I have access to, and then reading that information and seeing, okay, this looks like a trusted resource. Oh, this person looks like me, and they're actually part of the development. So now I'm trusting it. I'm privileged in that manner. When thinking about other communities who don't have this type of information that's always around them, and the type of information that they have around them, which is, misinformation, that's what's going to just kind of continuously, ring in their ear. So we have to also consider that too, right? So listening to people, providing them, correct information, authentic information, but at the same time, not putting them down for what they've heard as well, because that's going to create, barriers and tensions between the two people, right? It's just like any political conversation, right? Because if you're there just like battling out, you're not going to go anywhere.
Sure. But the stakes here are so high because in that battle, if it's over the Thanksgiving, dinner table and you don't like what your, uncle is saying, you will see. I'll see you next month, or I'll see you next year. But here, it's the stakes are much higher,
Right.
and I think it's
right.
Yeah, Lori. I mean, just to anything that Jasmine was just talking about, you wanted to comment on. We're almost up on time. I have one more question I wanted to get to. But Lori, go ahead.
Yeah, sure. I mean, it's critical. I mean, we've seen the hesitancy from staff, and I totally agree with Jasmine. You have to meet them where they are, figure out what the concerns are, and how can you address those concerns. And it's not a one and done. It has to be an ongoing educational experience. And the same is true for residents. While the vaccination rates among the residents themselves are much higher at this point, residents we've talked to all were very concerned. And at the same, you had to meet them where they are and get them the information that they needed that made them then comfortable to make the decision to get vaccinated. You can't force it on people, but it is critical. We've seen the vaccination rates have been critical in terms of watching the numbers decrease in terms of the spread of COVID and the deaths in long-term care facilities. And that's what's also spurring on getting families back in. So we really do need to get this moving forward and figure out a way to make people feel comfortable with the vaccines and get them the information they need that will allow them to feel comfortable to accept it.
Yeah.
So we're almost up on time, but I had one more thing I wanted to raise. And Lori, to you first. I'm putting myself here in the shoes of, I'm thinking about my grandparents a lot in this last year. And of course, nobody wants to go into a nursing home, probably if they don't have to, but even into any kind of congregate living situation or an assisted living facility. I would think long and hard before I went into one of those facilities now. Mm-hmm. Keeping in mind, of course, the decision not to has its own implications in terms of cost. Where can I afford to live? Or can I live with family or a brother or a sister or a cousin, or find a group of neighbors and somehow we form a community? I mean, I would be thinking creatively and be thinking long and hard, particularly based on everything I've heard from you both today about problems with regulation and preparation and transparency in the industry, before I just assumed, well, somebody must be making sure that I'm going to be healthy and I'll move right in. I wonder if you share that view, or more generally, what you think about the long-term impact this is going to have on people's decisions to move into these kinds of care facilities and these kind of living situations.
I think people absolutely are rethinking their decisions, and I think there's increased pressure to make other settings and options, available for people in order to receive care. People generally want to stay home. They want to stay with their family, and I think as a society, we can make that happen. And I think that now there's increased pressure in order to do that. As I mentioned earlier, we've been moving a little bit in that direction, step by step, where there are increasing supports for the availability of Medicaid to allow people to stay at home, even helping to pay sometimes family caregivers to provide some supports. But I think we're really going to need to see that on a much bigger scale in order to help people stay home. And I think as people are looking at their options, we also are going to need to rethink what nursing homes look like. The nursing homes that were smaller, that had fewer residents in them, fewer people coming and going, they did much better than the bigger nursing homes with lots of beds and lots of halls. So I think we need to relook at the structure of what we're paying for in nursing homes. But as people look at their options, they really do need to be asking questions about staffing levels. They need to ask about COVID rates in the facilities. They need to ask about emergency plans. Really, they need to be educating themselves on what are the services they're getting, what are the protections, and what are the plans in the facilities to protect them if they do have to go into a congregate setting.
Jasmine, just the last word from you. Thank you, Lori. Just last word to you on this.
Yeah, I agree with everything that Lori just shared. Nursing homes cannot continue the way that they've been going on for these past years. It's an absolute need to redesign nursing homes. And a piece that came out last year was titled "Defund Nursing Homes," right? But it was with this idea, like I don't want nursing homes to go away, right? Nursing homes aren't going away. We need to redesign nursing homes so that it can meet the needs of our most vulnerable populations and create this home-like environment. So what Lori was talking about and describing is in regards to these small nursing homes, the greenhouse model. They have about 8 to 10 members within their setting, and they did very well. It's this place where dignity is maintained, respect is maintained, it's decentralized, the staff are happy, the residents are happy. It's a place where you don't go in and you feel like you're in a hospital or you're in a ward, but you feel like you're in, your home. There's private rooms. So what does nursing homes look like after this? And when thinking about the questions that we ask, right, it's so easy for us to say, family members, make sure you go in and you research the nursing homes, but they don't know what the questions to ask, right? They don't know how to assess these nursing home quality metrics that really aren't even reflective of the care that is being delivered in the setting. So we really just need to make nursing homes, for one, accountable when it comes to person-centered care, when it comes to staffing, when it comes to turnover. We need to include those into the metrics as well, right? Where turnover is a metric that is measured, so that now nursing homes are investing in recruitment and retention efforts, where person-centered care, whether it be satisfaction surveys by residents and family members, that is satisfaction surveys among these members, that is part of the metrics as well, so that we're really investing in quality care and person-centered care in these settings. And then also with this whole idea of defunding the nursing homes, it's saying, it's making sure we know where these monies that nursing homes are receiving, where they're going. That a percentage, whatever that percentage that we say is the sweet spot, that is going towards staffing, that is going towards quality care, instead of just giving these nursing homes whatever and say do whatever you want with them, so that we don't see those cuts when it comes to staffing, and then providing the supports that nursing homes need. And yes, there were a number of supports, but what does this temporary staffing look like when nursing homes are in need for the next type of emergency? So just kind of this whole idea, reframing, reimagining nursing homes, but also thinking about how we allocate various funding and providing additional funding towards areas that need more attention.
You are both such powerful advocates. I'm so impressed with the efficiency that you can make these arguments and cases. And I know today isn't the first time you've made these cases, so you're really on point. But I really have hope that you're right. I mean, this should launch an era of reform around nursing homes. And I'll have to bring you back in a few months to check in with you both and see maybe we will see some positive signs along these lines. But I think it also won't happen we've been talking about ageism more generally. I think there'll need to be a political movement which will transcend some of these more specific recommendations that you've both made. I just want to remind folks that you can catch COVID Calls at 5:30 every weekday, 5:30 Eastern Time every weekday. And tomorrow I'll be talking about historically Black colleges and universities and public health in Nashville. So please do join me for that conversation. And just to thank my guests again, Jasmine Travers and Lori Smetanka. Again, I've kept them too longer than I said I was going to keep them today, but it was I learned so much in this conversation. Thank you both so much for your time.
Thank you. It's a pleasure to be here.
Yes, likewise. A lot of fun.
Stay healthy, everybody. We'll see you tomorrow at 5:30.